Our topic today is one of my favorite. It's anterior uveitis, and I hope if someone of you has this as a big struggle, that by the end of this lecture it will be a little less tense for you and more organized and better, and you would end up with keys of thinking about anterior uveitis. Now, I want to start with this case. It came yesterday to my clinic, and the moment I saw it, I thought this should be a very nice case to start with you guys. So she's 57 years old, Pakistani female. She came to my clinic referred from another colleague, post-cataract surgery in Pakistan in August, okay? She was seen there, she had photos, June, July, everything was fine, but, the surgery was in June, and the complaint started in August in her left eye, the pseudophakic eye. According to the patient, the surgeon said this is one of my cleanest surgeries, and the patient kept going there every 1 week by history. She told me I would visit the doctor every 1 week. But after 6 weeks, the vision started to become really blurred. She was not significantly photophobic, but bothered by the disturbed vision. She said right after surgery, she was able to see well, but then on the week 6, everything became zigzag and irritable. Now this is a video, excuse me, there is audio. I did not edit it. Okay, I want you to tell me what are the findings you see here. You can all talk. What do you see?
So medium size KBs.
Okay.
It's a clay +1 cells.
Okay.
+2 to 3.
Yes. Okay.
Clearly, so I didn't see any iris nodules before this section.
Well, there's something unique about the iris. It is what?
Dilated.
Dilated. The patient is kept on cycloplegic agent. And she has 3+ cells, as you mentioned. She has KPs. Who wants to tell me more about the KPs? Are they mutton fat? Let's repeat. Someone said they are medium size. Yeah, this is more of a medium size. Mutton fat تكون كبيرة وبيضة, and كبيرة وبيضة, and they are stuck to the Okay, these are more of medium-sized, distributed almost all over the cornea, but mainly condensed inferiorly, صح? Some of them are gray, some of them are brown, which gives me the indication of chronicity and still active, صحيح? I do not see frank stellation, but if you magnify, some of them are stellated, okay? This is post-cataract surgery. So you as a physician in the ER, and this patient comes to you, how do you approach this patient? What do you think about?
As differential.
Yeah, you are the physician وهي جاية تسألك. She's coming actually to take multinational opinions. She wants to know what to do with her eye.
Yes, I have to roll out endophthalmitis.
Okay, so endophthalmitis, and by that you mean late onset chronic endophthalmitis. What are the signs you are looking for?
I will look for the plaque in the IOL.
Plaques on the IOL. Now, I took a good shot of the IOL. Did you see that? There was no plaques, but that's a good thinking. غيره.
Lens-induced uveitis.
What do you mean by lens-induced?
Remnant lens material.
So you have two lens-induced uveitis. One is it remnants of the lens material in the vitreous, and the other is malpositioning of the IOL rubbing on the iris. صح? So you have two factors. تمام. Okay. So in order to do that, what do you do?
Careful
Retroillumination.
looking for the anterior or
Okay.
doing dilated fundus examination and seeing the
Tamam.
posterior fundus to see if there's any lens material. If there's no view of hazy, it will be scanned.
So, ممتاز. So, good thinking. So you are thinking in the right way. First of all, endophthalmitis. Second of all, lens or IOL induced. So I did for her B-scan. It showed vitritis, and the ultrasonographer told me, I'm not sure, but there may be some lens material. This made me go back to the patient and ask her, did you have a complication during surgery? She said the surgeon said it was the cleanest surgery he has ever done. So I still don't know, especially that in history she's telling me she's going every week to her surgeon. So I was still anticipating something. طيب, how can I manage this patient now? هي already جايتني بتاخد Pred 40 every 2 hours. على cycloplegic and on 4 anti-glaucoma combined طبعا medications. What comes to your mind? She is compliant to treatment. أول شيء نسأل عن compliance تمام. She is compliant to treatment. So despite taking steroids, انتوا دائما فكروا بهذه الطريقة. Despite taking steroids, this patient has severe inflammation. Something fishy going on. نرجع back بالhistory. This inflammation started 6 weeks after surgery. صح ولا لا? So what is this kind of inflammation that starts 6 weeks after surgery? Doctora suggested chronic endophthalmitis. Signs عندي are not really coming with chronic endophthalmitis. What should I be thinking about now?
Previous uveitis triggered by surgery.
ممتاز. She said I don't have, but you are right. What are you thinking about? You are correct. There must have been something underlying you that the surgery triggered. What are the things that surgery triggers?
What about the other eyes?
Normal.
Reactivation.
Of
Infectious.
like
Also TB.
TB,
Also.
herpes. هدول أهم اثنين. I'm screening her now for 2 of them. تمام? This is what I have done. طبعا what do you do to screen for herpes? PCR صح؟ ما في PCR. So what do? You give the patient the benefit of doubt. And you start the patient on oral antiviral and see in 3 to 4 or 5 days how is she doing. And when you give it, you don't give a minimum dose. You give the proper therapeutic dose. Valtrix 500 milligram TID. And if it's a zoster, you start with 2 tablets, يعني 1 gram TID. تمام? And if you are in doubt between HSV and CMV, you give Valgan cyclovir. ماشي؟ تمام. That's good. Good exercise. تمام. So this is a patient with uveitis. Anterior uveitis means inflammation anterior to the pars plicata. So any tissue like ciliary body, pars plicata, iris will be a part of the anterior uveitis. Sometimes the anterior uveitis have spillover behind in the anterior hyaloid, and that's when we call it cyclitis. This is the other subtype. So we have iritis, iridocyclitis, and cyclitis, depending on where most of the inflammation is situated. If you have anterior hyaloid inflammation and ciliary body injection, you can see ciliary injection on the conjunctiva, so this is cyclitis, this is not intermediate uveitis. عادة intermediate uveitis is not associated with redness of the eye, just to let you differentiate clinically between the 2 of them, okay? The incidence of anterior uveitis worldwide is, عشان أحط لكم إياها, is between تقريبا 10 to 15% cause of blindness in the developed countries. In our country here, this is one of the only actual paper I found about prevalence of anterior uveitis by Prof. Tabbara was 60%, and by Dr. Abu al-Asrar was about 20 to 30%. طبعا كل واحد فيهم بيشوف شيء, but that's why their percentages are a bit different. However, uveitis anterior is the commonest presentation of uveitis worldwide. Now you all know about the sun classification, or should I go through it? The onset, is it sudden or insidious? Duration, is it limited, less than 3 months, or persistent for more than 3 months? The course of the inflammation, whether it's acute, and this we say if it's sudden and limited, يعني it happened quickly and less than 3 months. We say it is recurrent if it is repeated attacks in less than 3 months with a little bit of relief in between. And we say it's chronic when there is persistence of inflammation for over than 3 months despite treatment. Now, anterior uveitis, according to etiology, أحب أقسم لكم إياها into 2 main categories, whether it's infectious or non-infectious. The infectious etiology stand for 30%. The non-infectious تنقسم عاد 30% autoimmune, post-traumatic, and masquerade and idiopathic will take the 40% remaining. ماشي? Now, the symptoms and signs are, as you know, pain, photophobia, recurrence, redness, blurring of vision, headache, tearing, and it can be even asymptomatic when the patient is brought to you for screening. The fate of eye with uveitis is crucial. You know that uveitis, you all should know that uveitis is not something light. It is a blinding disease. If not treated. حتى simple uveitis might turn out to be a blinding disease if the patient developed glaucoma and it was passed unnoticed. Cataract is the easiest to treat. Band keratopathy can be cleared. Glaucoma is the one you are fearing, and of course retinal detachment, ptysis bulbi. You should not leave a patient with uveitis untreated or neglected. Now, these are the findings that I'm sure you know this slide from my previous lectures very well. You should look to the conjunctiva, cornea, anterior chamber, iris, lens, vitreous, retina, optic nerve, and ora serrata, even if you are screening just for anterior uveitis. And this should be done in each and every visit, and I'll tell you in a little story now in a coming while. In the conjunctiva, you look to the ciliary injection, look to the pattern, is it diffuse or sectoral, which vessels are involved, and by this we use the phenylephrine test to know if it is the superficial vessels, intermediate or deep vessels. Rule out conjunctival discharge, follicles, and papillae, because viral HSV, herpetic conjunctivitis, can be present in at least 20% of your cases, and you need to rule out corneal infiltration and dry eyes. Sometimes the patient may come with scleromalacia and necrotizing scleritis without pain. All he comes to see is this pigmentation changes in the color, like the inferior picture, and the patient will have like impending perforation. So you need to lift the upper lid to complete your examination and look for the hidden areas. The other signs in the cornea, you will have keratic precipitates, corneal edema, and band keratopathy. Now, what are the keratic precipitates and how do we assess them? You know the size, color, shape, and pattern of distribution. Keratic precipitates histopathologically are, if they are just fine, keratic precipitates are lymphoplasmatic inflammatory cells, and if they are the granulomatous type, they are usually epithelioid cells. Now, this is the difference between them. Any KP that you can draw and delineate is a granulomatous KP, okay? Any KP that you cannot define, like the picture on D, is like a dust-like, these are non-granulomatous KPs. واضح هذا? Now, sometimes the patient comes to you on steroids, and you cannot tell if the patient, what did the patient have before. So in this kind, in this situation, you have to write patient is on treatment, undetermined type of KPs. ماشي? Unless you can see that there was a KP and it is shrinking. If you see it, it's there. But you always have to mention patient is on treatment or not on treatment. So now, if you are not so expert, there's a paper published in 2009 in the Eye Journal using confocal microscopy to describe the types and shapes of keratic precipitates and what material. You can take the lecture, doctor. It's all for you. Okay, what type of keratic precipitate will come with what disease. And I find this very interesting. However, confocal microscopy is dependent on the technician. And if the technician is expert, you will have good result. If the technician is still an amateur, you might not take benefit of it. So they have defined it as the shape, size, glistening effect, and to 5 categories. And the smaller type is type 1 and the bigger type is type 5. 5 and 4 are the same size, but one of them has glistening effect and the other has not. And they found, interestingly, that type 1 is present in Bahjat and juvenile idiopathic arthritis. The infectious Fuchs and infectious uveitis are of type 3. HLA-B27 are type 2. And I find this very interesting because clinically you actually see difference in the KPs if your eye is trained to see the difference between them. Now, keratic precipitates, we know that Fuchs, مين يقول لي يلا؟ Fuchs إيش نوع ال KPs فيها؟ Stellate, distributed all over. Is it granulomatous or non-granulomatous? عيدوا الجواب. يا ريت معايا مصطفى الأساتذة. عيدوا الجواب. Fuchs uveitis is what? Granulomatous ولا non-granulomatous? Granulomatous. كانسكي كاتبها خطأ. Fuchs is granulomatous. واسألوا فيها أبو الأسرار واسألوا فيها الناس. Fuchs is granulomatous uveitis. تمام? The first time Fuchs was published in Germany, he was describing a granulomatous disease. تمام? It is microgranulomatous stellate KPs distributed all over the cornea. And when you look for your answers, be careful where are you getting your sources from. Sometimes Google is not the right answer. تمام؟ Sometimes Google does not give you the correct answer. وأنا هذه المشكلة إنه كل مرة أقدم عن فوكس أتكلم فيها هذه الكلمة. وأرجع أشوف الإجابات again غلط. So please be careful. Fuchs is a granulomatous uveitis. تمام؟ اللي بعده. Let's talk about HSV. كيف الكيبيز فيها؟ طبعا أنا بسألكم لأنه المفروض إنه هذا repeated talk for you صح؟ You all know. ولا أنا غلطانة؟ غلطانة؟ I know most of you guys, and I know that you have heard this lecture many times. So, KPs with HSV have been found to be colored. They are not white and gray. They might be light brown. HSV and CMV. الفرق بين الاثنين distribution. HSV عادة يعطيك disky form located in one area and in a plaque-like. CMV يكونوا larger وبعاد. Okay, they can be in the periphery, 1 or 2. طبعا في overlap, لازم يكون في overlap, but this is the commonest. The bigger the KP, the more it is towards CMV. The more confined the KP and located group كده مع بعض, the more it is with HSV. Okay, تمام. Let's see this. أول واحدة على اليسار. What is this? Okay, this one. ما يبين عليكم الكرسر. هذول ايش؟ يعني جرانيولوماتس ولا نون جرانيولوماتس؟ شكرا جزيلا. وهذول تقريبا في مكان واحد، صح؟ هذه distributed down، وهذه عادة نشوف معها شيء اسمه Arlet's line، تمام؟ This is more towards it. وهنا في كلو، ايش الكلو؟ يعني هنا نحطها ايش؟ شكرا. خلاص. So HZV, CMV, HSV all will come with these kind of keratic precipitates. However, the size is different. Modern fat larger KPs will come with أشياء الأوسس, tuberculosis, sarcoidosis, toxoplasmosis, and birdshot retinopathy. ماشي؟ And if you have iris atrophy, you have to think of HSV and HZV أكثر. You also need, for anterior uveitis, to check the corneal sensation. And please make this a habit in each and every patient that comes to you, because underlying HSV silent is very common. Look to the iris and how it changes according to the progression of the disease. So here, you can see, I think this patient started with normal iris, and this is, I think, the other eye of the same patient, and you can see the difference. Now you have to be aware that patients with dark irids will have lighter cornea, lighter iris with the inflammation, and vice versa. Patients with light iris will have a darker iris with the inflammation. Cells and flare, you know the Tyndall effect and the grading of the anterior chamber cells, and you should not miss doing gonio because you might find fibrillar or white or deposits in the angle. The classification of the anterior chamber cells is crucial to know when is it from grade 0 to grade 4, and I'm sure most of you knows how to do this. The laser flare photometry is a machine that is not present in most of the hospitals, but it is another diagnostic tool that tells you if the inflammation is active, and it speaks more about the flare, not about the cells. It is good if it's available. However, you should not rely on its presence to treat patients. Now, some doctors stop treating patient if the patient has only flare, especially in juvenile rheumatoid arthritis. And this practice is not correct. The presence of flare means the presence of activity. Flare is as active as anterior chamber cells, okay? So the patient should have 0 flare to say that the patient is quiet. Flare means very subtle chronic activity. But the flare can be treated with non-steroidal anti-inflammatory rather than only steroids-like cells. The iris can speak a lot, heterochromia, iris atrophy, whether sectoral or diffuse, and the one who said you look by retroillumination. By retroillumination, you look for iris atrophy. Cope and Busaka nodules, I'm sure you know about them, the presence of iris new vessels and the broken synechiae. So you know the difference between Cope and Busaka? So Busaka nodules are all over the iris. Cope nodules are on the pupil margin. Cope nodules can be the site of synechiae. So Cope can happen in both granulomatous and non-granulomatous. The presence of Cope does not mean this is granulomatous uveitis. The presence of Cope اللي هي على pupil margin means there is something going on, and at this site you will have synechiae. You need to keep the patient on cycloplegia to avoid the presence of synechium. تمام? And I'm sure you know what is this? Leash nodules. This is not copy nodule. Okay. Now, iris atrophy is another clue. Sometimes you don't see iris retroillumination, but you see that the sphincter muscle is paralyzed at a sector of the pupil. So you look at the pupil as it dilates, it's not regular. This irregularity tells you that this point of the iris has atrophic muscles, and this atrophy happens usually with HSV. Okay? The presence of broken synechia from a previous attack patient gives you a clue that this patient had a very severe inflammation. Now, when a patient comes to you with a fibrinous reaction like this, عادة, it is less common to be of herpetic etiology. Usually these are cases of HLA-B27 or HLA-B50 related diseases. Okay? Usually. But هذا لا يعني إنه herpes cannot come, it can come. Now, you have to take clues from the history of the patient. This is a patient who developed something after giving oral moxifloxacin. Let me tell you about my story with moxifloxacin. I had this young man, he was 17 years old, he had very high myopia, he was like minus 18 in both eyes, he was wearing contact lenses and spectacles. I was able to put for him ICL, and the patient was very happy after surgery. A month after surgery, actually not a month, 2 weeks. 2 weeks after surgery, the surgery was very smooth. He came to me with severe inflammation, mainly pigment dispersion syndrome-like. Now, I reviewed his case, his IOP was going up, we were managing him with oral and systemic anti-glaucoma medication. Eventually, the patient settled down, but when I started taking history from him, 2 factors came up with him. Now, I contacted the company and they told me, did you use intraocular moxifloxacin? And I said, yes, this is the antibiotic I'm using in my eyes, in my patients. They said, well, this can be one factor. And the other factor is the patient practicing exercise. Well, he's a weightlifter. He told me, yes, 10 days after surgery, I went back to my strenuous activity. So sometimes these patients can be misdiagnosed as uveitis, and they are not uveitis. It's just pigment dispersion syndrome, secondary to either medication or aggressive exercise. Okay, so keep this in mind. You need to know what type of cells you are dealing with. The presence of rubeosis iridis is crucial, but you need to rule out before thinking about uveitis, you need to rule out what? System. So ocular ischemic syndrome. So the first thing to make sure you are not missing is ocular ischemic syndrome. Intraocular pressure is a very important clue for uveitis. Some diseases have very high intraocular pressure. أولهم Posner, then HSV, and least of them is Fuchs, and Fuchs is usually steroid-induced. You can have hypotony in active inflammation like VKH, HLA-B50, Behçet disease, and like Reiter's syndrome, ankylosing spondylitis. عادة when they have activity, they have ciliary shutdown. بينما بالviral induced, تكون في trabeculitis and iridocyclitis inflammatory that causes high IOP. فالفرق بينهم مرة مهم. Okay, now the tips. You need to ask the patient about the onset, the duration, the recurrence, you all know this, the medication the patient is on, any history of surgery, سواء recent or previous, unilateral or bilateral or alternating. Let me tell you about this patient who came to my clinic referred from another colleague. He told me, Anoud, this patient has episcleritis, scleritis, ماني عارف ايش فيه, bilateral, كل شوية أديله steroid يرتاح بعد أسبوعين he flares up again. So the patient لما جلس قدامي قال لي دكتورة أنت مستعدة تسمعيني؟ أنا حكايتي طويلة. I had a very busy clinic, but I had to really listen to this man and see what's going on. He told me I have something called SAPHO syndrome. قلت له نعم. قال لي I have SAPHO syndrome. Now, أحد فيكم يعرف what is SAPHO syndrome؟ أنا أول مرة أسمع فيها كانت في حياتي. تمام. And I have this hypersensitivity reaction, dermatitis. I cannot be exposed to sun. ناقصني أنا. شوية بيقول لي أنا عندي colon cancer. والمريض طلع عنده فهرس هاريسون من الدايجنوزز. Eventually لما أخذت منه الهيستوري قال لي أنا أخذ biologics، أخذ هيوميرا for at least 2 years now. لكن الآن ارتفعت عندي الليفر enzymes فوقفوا لي الهيوميرا. ولما وقفوا الهيوميرا I'm okay fine my skin is fine and يعني I'm dealing with it. قال لي بس هذه عيوني ما هي راضية ترتاح. Now here was the click. The patient, I told him, when did your eyes start getting inflamed? Before stopping Humira or after stopping Humira? So he kind of thought about it and he said, well, I think it was 3 weeks after stopping my Humira. Now this is the answer. The patient's disease, it was suppressed by the Humira, whatever the condition is. And stopping the medication flared up his eye condition. So I gave him, since I cannot put him back on Humira, I just gave him a short course of steroid and I put him on tacrolimus eye drops to halt the inflammation of the anterior conjunctive, anterior scleritis and episcleritis. Okay? So history helps you guide the patient to the diagnosis. Tamam? You always need to examine both eyes and make a difference between granulomatous and non-granulomatous inflammation. And you have to see your patient quite often. Sometimes you can tell the patient, please stop all the medication, let me see what's going on with you. Okay? To get the real assessment of the patient. And know what part of the eye you are dealing with. Now, this is I'm sure you all have this table. What are the inflammatory causes of anterior uveitis and impanic uveitis? We have very common inflammation of Fuchs, herpes, CMV, Postner, sarcoid, TB, and syphilis. And in panuveitis, we go more towards the OSIS, like sarcoidosis, tuberculosis, toxo, necrotizing retinopathy, and post-surgical inflammation. The non-granulomatous inflammation, like HLA-B27, Behçet juvenile uveitis, scleritis, TINU, drug-induced, and sometimes it's surgical and may be confined only to the anterior uvea. What workup do we do? You always have to ask about the age, gender, and race, put them at the back of your mind. Determine the severity. Dilated fundus exam is a must, and I actually do fluorescein angiography in almost 100% of my patients when I see them for the first time, and because there are some subtle things that I cannot see. If the patient is HLA-B27, you will think of these diseases. If the patient is HLA-B27 negative, Behçet and seronegative psoriatic arthritis is a must to keep in mind. Now, as I will come in the lecture, you will find out that the entity of seronegative psoriatic arthritis is very important because the gap between the ophthalmic findings and the skin or joint findings can be up to 10 years. Okay? 10 years difference. In children, juvenile idiopathic arthritis should be your number one, ANA positive and RH positive. If it is TINU, you are suspecting tubular interstitial nephritis with uveitis, all you need is a urine analysis. If it is too aggressive and your surgeon or your physician can go for that, you can take a renal biopsy, but usually it's done just by the urine analysis looking for beta-2 microglobulin levels. In teenagers, you need to rule out, again, juvenile idiopathic arthritis, TINU, HLA-B27, and B51. So let's skip this, since you all know the granulomatous. Okay, so granulomatous uveitis can be a little tricky because the inflammation is very aggressive and you can have significant posterior uveitis and you are not aware about it. So dilated fundus exam is a must and you should see the ora serrata. It is very common to have herpetic uveitis as granulomatous and as non-granulomatous. So it is always your great mimicker and it should be your top one in your differential diagnosis. You may do PCR, but your clinical judgment is more than enough. It is safer to give the patient antiviral than leaving him alone. Now here is the مين في شغال في الملك عبد العزيز هذا الشهر؟ King عبد العزيز Hospital. في أحد في الجامعة؟ في أحد شاف المريض فهد العثمان؟
Yes, sir.
You?
Yeah.
Okay. So this is my patient. He came to my clinic, I think, في منتصف November. Yeah. So he came to me with KPs in the anterior chamber. You saw the KPs. They are big, small, big and pigmented, and in the inferior. You saw how they were distributed in the inferior arc?
Yes.
So I told him you have a viral uveitis. I'm not sure this is HSV or CMV. The moment he came to me, he did not have anything at the back of the eye. He only came with anterior uveitis. Now this patient, a year ago, developed generalized vitiligo, severe eczema. He cannot sleep because of itching. He was transferred to Germany to see what is the underlying cause. They told him this is drug interaction. So the patient became very cautious about any medication anyone would give him. So he stopped taking most of his medication just to make sure that he is not getting another side effect of the treatment. Now this gave me a very big burden because the patient is reluctant and does not understand that the disease he's having can be serious. I tried to see him every week twice, but he refused. He would come twice a month only. And he gave me a hard time. I used to call him at home and to see, can you come? I wanted to see your eye. He said, I'm fine, I'm seeing well. I told him, I really need to see you because you might feel that you are fine and he's one-eyed patient. This is his only good eye. So the patient eventually came. I gave him Valgan cyclover. It took a while for him to find it. ولما لقاه قال أنا حبدأه في بداية أكتوبر. يعني أنا ما أبغى أبدأه الآن. أنا حبدأ في بداية أكتوبر عشان ما أتلخبط. So he started in October. Unfortunately, when he came, after starting it, a week after starting it, his vision improved from 2200 to 2060. So I was relieved. But on fundus exam, I could see this area of patchy necrosis. I told him, we have something new, but you are improving. I will just observe. He did not come. He came 2 weeks later. 2 weeks later, when the medication finished. And then I told him, I told you I need to see you twice a week. He said, well, I cannot come for you twice a week, and I'm feeling better, but today I think it's a bit blurry. I thought that he started to have vitritis. So I told him, maybe it's time now I need to give you I will give you peribulbar steroid because he refused oral steroid. He refused IV acyclovir, and he said, I will only take the peribulbar steroid. I gave him the peribulbar and I told him, you need to come 3 days later. He came after 3 days and then he had this severe fulminant vitritis. I told him, by now, I'm going to lose your eye. You need to go see another physician and you need admission because he was refusing all my treatment. فeventually حولناه وما شاء الله الدكتور بلوشي and Dr. أبو الأسرار were able to give him intravitreal again cyclover and did for him RD repair with the silicone oil. I think he's fine now, صح? Yeah. He's fine. تمام ممتاز. And who saw Rayyan? Rayyan, the panophthalmitis child, 14-year-old. برضو راح للملك عبد العزيز. أنت؟
Rayyan, he's my patient.
Your patient?
Yes, طارق الزاحم أنا consultant في الملك عبد العزيز.
أهلا وسهلا. Thank you very much.
I don't know Rayyan.
ريان أنا كنت مسافرة قبل لا أطلع من المستشفى قالوا لي تعالي شوفي. One of the registrars. فشفته قلت لهم he has panophthalmitis and this could be شو اسمه اللهم صل على النبي. He could be sinusitis or endogenous endophthalmitis. فحولنا الكيكش. I don't know what happened after that. أمه كلمتني قالت لي إحنا في عبد العزيز. I'm not sure what happened.
Yeah, so I think he went to Kekish because of the sinusitis issue and the absence of ENT team here.
Okay.
He was referred to Al Madina, and then at the end he went to our hospital. I think because he was having, I mean, in Madinat Makfahad there was no oculoplasty team as per them. So the patient came to us actually through the oculoplasty on call.
Okay.
For the orbital cellulitis part of panophthalmitis. Anyways. He was having significant choroidal infiltration. So it is most likely it is an endogenous endophthalmitis, not sinusitis related orbital cellulitis, because it's very rare to have intraocular infection from a sinus source. It is very common to have an intraocular infection and spreads to the orbit.
Okay.
And the sinusitis issue most likely was related to, the cold that is very common.
He had frozen globe and he was only light perception when I saw him.
Yes, he was light perception when we discharged him, but he's significantly better. Now he's 360 synecia, no view to the fundus. He was having significant exudative total retinal detachment, but now he's much better.
Did you find the organism?
Actually, he was on vancomycin and meropenem 10 days before he was sent to us. So blood culture, urine culture,
all negative.
All negative, and we did not do any intraocular. We did not take an intraocular specimen because of his.
And it's not a case of bahjat by any means.
No. The other eye was okay, and it is not bahjat.
It's good to see an update, صراحة. لأنه I'm concerned about him.
He's doing fine. So the only issue for him is that he's at high risk of phthisis. This is the issue because of the severe infections.
So uveitis is blinding. You need to be careful about it. Okay. Now this is one of the tables I find useful for you if you want to go back and read about it and see how you investigate patients with uveitis. You can take a picture of it. It will be very easy access. Now, case for infectious uveitis. When do we do PCR? When you are in doubt, when the patient is immunocompromised, when the patient is resistant to your treatment, because PCR is quite expensive, and most of the studies have shown that it will not change your management plan. This is one important paper that all of you should read very well. It is about demystifying viral anterior uveitis, and I find this very, very helpful guide for viral uveitis. Sorry. Now, it's in summary, they have divided it into two: Fuchs-like and Posner-Stossman-like. Fuchs-like الناس اللي تجيها very mild inflammation, chronic, low grade, الIOP ما هو مرة عالي, and inflammation usually is related to either rubella or CMV. So rubella is in the Middle East, rubella is in the US, but in China and Japan it is related to CMV. ماشي؟ نيجي للبوستنر-like اللي هم inflammation usually male more than females, very marked high IOP, and usually it is in one eye طبعا, and the KPs are significant. It can be one of the three: HSV, VZV, and CMV. The higher the IOP, the more CMV-like. The lower the IOP, the more HSV-like. And the difference between them can be very difficult clinically. Sometimes you need to give a broad-spectrum antiviral to treat both. واضحة هذه؟ CMV can come as both, as Fuchs-like or Posner-like, depending on the ethnicity and the epidemiology. And the Posner-like is mainly by HSV, VZV, or CMV. So non-infectious anterior uveitis. When should an ophthalmologist refer to a rheumatologist? The incidence of spondyloarthropathy in acute anterior uveitis. The old school, when we were residents, we were taught if the patient comes to you with acute anterior uveitis first attack, give steroid and send them back home, bring them back in 2 weeks, check IOP, and that's it. This was the wrong teaching, because now, if you look back to the papers between rheumatology and ophthalmology, the prevalence of spondyloarthropathy in acute anterior uveitis is very high. In 2016, the Spanish analysis was done for 780 patients. 50% had axial spondyloarthropathy, 17% had peripheral spondyloarthropathy, and the incidence of HLA-B27 was positive, was very high. Again, another sophisticated study used MRI in patients in UK. 73 patients had chronic back pain before the age of 45. All of them underwent MRI and had signs of axial spondyloarthropathy. 20% had peripheral axial spondyloarthropathy, and all of them had anterior uveitis. Now, the incidence of extra-articular manifestation, this is another study in 2021, compared ankylosing spondylitis, undifferentiated spondyloarthropathy, and psoriatic arthritis. This was a Swedish study that compared 3 cohorts, and guess what they found? Uveitis was present in ankylosing spondylitis more in males than females, and about the ratio of 15 to 8 between them. In undifferentiated spondyloarthropathy, males again were higher, and that was the ratio of 10 to 6. In psoriatic arthritis, it was only equal, and they were like 2.5%. Inflammatory bowel disease in ankylosing spondylitis was about 6%, 5% in undifferentiated spondyloarthropathy, and 2% in psoriasis. In psoriatic dermatitis, they found that it is 2.5% in ankylosing spondylitis. Undifferentiated spondyloarthropathy had 3.8%, and it was minimal in psoriatic arthritis. The rheumatologic keys here اللي انتوا لازم تطلعوا فيها انه ankylosing spondylitis, undifferentiated spondyloarthropathy are strongly associated with future anterior uveitis. So if a patient is diagnosed with ankylosing spondylitis, comes to you for screening, don't tell him you don't have uveitis now, you can go home. Tell him I need to see you annually. Okay? This is the key for you. And patients with psoriatic arthritis are at very high risk of developing anterior uveitis, although they are seronegative. The Duet classification, the Duet شو اسمه study عارفينها? Okay, so this Duet study compared 2 groups, cohorts. This is very important لأنه يجي عليها أسئلة كثير. And they just compared group of patients that came for your first presentation with anterior uveitis. Some were asked about back pain, some gave history of positive back pain, so they screened them, and some gave negative history of positive back pain, so they did not screen them. And eventually they found out that patients who were not screened later on developed ankylosing spondylitis or some sort of HLA-B27. So the key from this study was to stress on screening every patient with lower back pain, in the age of less than 45 years, and anterior uveitis for HLA-B27 or psoriatic arthritis. Now the management depends on what you are considering. You can start with topical steroid. This is your first line management. You always need to make sure you are breaking synechiae and the patient is not left with high IOP. And if you are giving steroid, the patient should come back to you to check for steroid responder glaucoma. You need to see your patient soon enough, long enough, and make sure that you are not missing new symptoms or signs, especially in uveitis, because new signs can appear in every visit. Okay, the mydriatics you all know. What about the biologic agents? It is the best for now for non-infectious anterior uveitis is to use anti-TNF, and the least is anti-interleukin 17, اللي هو socicomab. Because socicomab is known to have less potency, and the patients with acute anterior uveitis will persist or they will develop it, and there are too many papers أنا مخليتهم لكم, you can all have them later. Okay, this is another case that came to me, I want to share with you. He was referred for uveitis. He is 65 years old, active male. He was diagnosed with prostatic cancer. His physician told me that when they started the new medication, I started to see this synechiae in his eye and uveitis. طبعا عين فيها synechiae, عين ما فيها synechiae. So I was subconsciously programmed that this is drug-induced uveitis. صح كده؟ قال لي هذا الميديكيشن فدخل في uveitis. And later on, when I decided to take him for cataract surgery, I was just writing for his physician, you know what, you need to make sure that there isn't an underlying herpes because he is immunocompromised now with anti-cancer drugs, and just be careful with it. He told me, go ahead, you do it, I don't want to do it, you be careful, you're the uveitis person, so you take care of that. I screened his file again in details before surgery, and I found this patient is having this diagnosis. You see what we have here on his lid? Do you see it? Does it look suspicious to you? ولا شكلها عادي كأنها إريديما؟ فأنا سألت المريض هذه اللي في عينك، لأنه مرة أشوفها مرة ما أشوفها، مرة تكبر مرة تصغر، إيش هي؟ فقال لي دكتورة أنا صدري كله كذا. فقلت له أنت بتتابع مع الجلدية؟ قال لي إيوه يا دكتورة أنا صار لي 4 سنوات أتابع مع الجلدية. يا حبيبي إيش فيها الجلدية؟ I found out that he has something called mycosis fungoides. فأنا مخي على طول mycosis fungoides. Who knows what's mycosis fungoides? Yeah, so it's a T-cell lymphoma. The patient was on methotrexate, very low dose, and apparently one of the rarest presentation is anterior uveitis. So this is not drug-induced uveitis. This is part of his T-cell lymphoma. Okay? بس لأني أنا ما قد شفت mycosis fungoides skin lesions, I did not catch it from the first time until I was taking him for surgery, and I wanted to make sure we didn't have any skin infection بصراحة قبل لا أدخل العمليات. Here is another patient that came to me with total corneal epithelial defect, and I think some of you might know the story. For 1 month, no healing, and the patient was contact lens wearer. She was diagnosed as acanthamoeba keratitis and was taken for amniotic membrane. But before the AMT, her family brought her to me and she said, "Can we take your opinion?" And when I saw, what do we call this white ring? What do we call it? Wesley immune ring. فاكرينها يا جماعة؟ Wesley immune ring. This patient had one solitary KP at one of the angles here. Okay? I told her, I think you have HSV, give me 2 days, let me see how you will improve. On the 72-hour, she had complete healing after starting topical acyclovir. Okay? So this was her eye after treatment. Now, who will tell me what this is? Shukran, folks. أحسنتم. So take home advice, close follow-up and monitoring response and side effects. The IOP and cataract are a very good clue for you to know what's going on. If in every visit you must repeat history taking and update new symptoms and signs to confirm or to change your diagnosis. Do not be stubborn and stuck to your diagnosis because sometimes you can change your mind. It's okay to change your mind. Do not be arrogant. ايوه هذه نفس اللي كنت بقول لكم اياها. تمام؟ يلا يعطيكم العافية.